Good morning from New York, and good morning on behalf of INEDCAST. I would like to welcome you all to this global audience for today's session. Today we have Professor Robert Gish. Dr. Gish, as you all know, is a well-known in the field of hepatology, in the field of hepatitis B. He's a fellow of American Association for the Study of Liver Disease and the American Society of Transplantation and the American College of Physicians. Dr. Gish co-authored a public health policy for liver health in Vietnam, focusing on hepatitis B, and is also assisting with the development of viral hepatitis healthcare policies in Georgia, Armenia, and Philippines. He was a major early contributor to decipher methods for the detection of hepatitis B and C virus and characterizing their epidemiology and clinical presentation in humans. He was involved in studies that led to genotypic classification strategies and methods now in use worldwide. He has published more than 700 original articles, abstracts, and book chapters. Dr. Gish is currently an adjunct professor of medicine at the University of Nevada Schools of Medicine in Las Vegas and in Reno. He serves as an adjunct professor of pharmacy at the Skaggs School of Pharmacy and Pharmaceutical Sciences at UCSD and a clinical professor of medicine at the Loma Linda University. In addition, he is a medical director of the Asian Pacific Health Foundation in San Diego, California, and the Hepatitis B Foundation in Doylestown in Pennsylvania. Dr. Gish is currently seeing patients both in person and via telemedicine at various clinics in San Diego, Folsom, San Jose, Santa Jose, and Valley Springs. He's staff physician at the La Maestra, a federally qualified health center in San Diego. Dr. Gish also serves as a board member of the Vietnam Viral Hepatitis Alliance. With that elaborate introduction, I would like to welcome Professor Gish.
Jaya, thank you so much. I really appreciate all your incredible work, education work.
Thank you, Bob. That was really wonderful, actually. It's a great overview of hepatitis B, quite exhaustive as well. And going from journey from vaccination to the surface antigen loss, you just covered the whole thing. I see there's a lot of questions in the chat box as well, but I would rather make it more interactive. If anyone has a question, if you please come forward, raise your hand, and let's have an interactive discussion today. I know we can start with some of these questions that was asked in the chat box. Dr. Burma, if you want to ask your questions on your own.
So my first question that I asked was that if you could briefly talk about, and I while you were talking, I subscribed to your website so that hopefully I can get the list, the document, as well as to different kind of medications that increase the reactivation risk. First question was if you could briefly talk about the type of chemo when you would go ahead and treat a surface antigen negative but a core antibody positive patient. And then would you treat everyone with TAF, which is Vemlidy, if insurance coverage was not an issue, and if you have ever come across any pushback from insurance when you follow your treat all approach. Also, I know as per the guidelines, the Vemlidy or the TAF so far has not been approved for pregnant patients. They still talk about TDF. In your practice, have you started treating pregnant patients with the TAF? I know I asked too many questions, but thank you so much for the excellent talk. It was very practical, very clinical, so I loved it.
Thanks so much. I'll try to go backwards, and maybe Sanjay, you can help remind me of all these questions. But let's take the TAF versus TDF for pregnancy first. And we have great data from Calvin Pan, plus a number of other investigators, that TAF is as good as TDF. TAF is as safe as TDF. So in pregnancy and in terms of preventing transmission. So if I have access to TAF, I would use that over TDF. I think it has a better effect on viral suppression. I also think it has a better effect on ALT normalization for some reason. We don't have the full characteristics of that. I think your first question, I'll bookend this for a moment, was about reactivation. There's a couple different directions to go as which medications have the highest risk. And of course, we know rituximab and the medications that modify CD20 are in a lead position there, or stem cell transplants, broad-based chemo with drugs such as Doxo, TACE, But that's a complex discussion. Sanjay, you may want to have a whole 90 minutes on reactivation this year. We've got a great paper coming out just in a few weeks on that. That's a real update. It's fantastic. My team did a great job writing that. You do need to assess in your surface antigen negative patients who may be at high risk for reactivation to check their DNA level. That means looking for occult hepatitis B, OBI. So if I have a surface antigen negative, core antibody positive, surface antibody negative patient, that's core only, I really do think about measuring an HBV DNA level. Not in everybody, but I'm worried about reactivation. They have elevated enzymes or something else peculiar about their case. I will check a DNA level. The fourth question, I think we're at 4 or 5 now, had to do with insurance access to TAF over TDF. And definitely people are pushing back in the US, forcing us to think about TDF or entecavir before using TAF. We've complained, we've gotten TAF back on a variety of formularies, including Optum in the US, fighting from the Hepatitis B Foundation to give patients access to the best medicine. TAF still is the best from a variety of different perspectives: safety, resistance, ALT normalization, DNA suppression. TAF, in my opinion, is your best option. And we will fight back. I'll fight with insurance companies and I'll fight with governments to do what's right for our patients. Did I miss anything on that series?
No, I think you answered everything. Thank you so very much.
You're testing my memory at this early hour of the morning here.
No, that was great, actually. I think you made a very important point about that the surface antigen negative, core antibody positive, but without an antibody yet. I think there's something funny in that, like you saying that doing a DNA. I think it's a very important point. I would ask you one question on that line, actually, just to clarify myself. I have seen patients where their surface antigen negative, core antibody positive, and sometimes the DNA fluctuating at a very low level. What to do in these patients? Are you going to, because that DNA level, by guidelines, we don't have a clear idea about how do we approach. Do we just keep watching, keep monitoring, or treat these patients?
DNA positive, treat. So I have an OBI patient. I just diagnosed one yesterday with my partners in San Jose. They sent me an email. I said, oh, this patient's a functional cure. I went through the chart. I said, wait a minute, they're still DNA positive. They're not a functional cure. You got to be S antigen negative, DNA negative to get there. So DNA positive treat, Sanjaya, very simple.
But do you are these surface mutant, surface escape mutant? Are these like surface antigen negative and the DNA positive?
It's a very good question. There are a variety of surface antigen mutants floating around, and Roche and Abbott had to keep making their surface antigen assay better. They detect most S antigen mutants, but there will be a few patients out there with a mutation that's not detected by these assays that our best diagnostic companies have. But it's the DNA that helps drive the disease state more than S antigen. So it's the DNA links to treatment. I think I'll keep it simple.
I see. And where do you send if you need to test for the surface mutant? I mean, in USA, at least, to my knowledge, I don't know. Where do I send it?
No, there's no way to get a surface antigen mutant commercially done.
I see.
Gavin Cloherty at Abbott, who's one of the best, test development persons in the world, is fantastic. But the Roche team has also really gotten very interested in fine-tuning their kits, their assays, their sensitivity. Roche is getting into the Delta world also, diasorin's in the Delta world. So interact with your colleagues if you want to try to get a special test done.
All right. Thank you so much. I'll move on to...
Oh, sorry, go ahead. I just want to tag on to the previous question in terms of, the pregnancy and the Vemlidy. I wanted to know if there's any data in post-transplant patients who have to be on anti-HBV medication, what the data is on Vemlidy and post-transplant patients.
So we have lots of data in pregnancy, and you can just send me an email or get a literature search, or we can shoot that to Calvin Pan. In transplant, the data is not head-to-head. There's no randomized trials, but we have data with entecavir, TDF, and TAF. that show that they're basically equivalent in terms of preventing reactivation after transplant. As you know, in the transplant world, we've gotten rid of HBIG in most settings. There's still some surgeons that hang on to HBIG forever. I don't know why they're doing that. The Hong Kong data shows you rarely need HBIG if patients are fully suppressed. So let's fight, get rid of HBIG, use our first line therapies post-liver transplant. That was a place where I might say lifelong.
I'll come back to that question because a lot of questions already there in the chat box about post-transplant scenarios. But let me mix up with this chat questions as well as some of the question that is coming up from our audience. So Dr. Tuseja, Ajay Tuseja, very well-known hepatologist from India. Dr. Tuseja, please go ahead.
Thank you, Sanjay, and thanks, Dr. Gish. That was a wonderful talk. My question is about the evolving approach about treat all with DNA positivity, which he really emphasized. But the issue is within this group of DNA positivity, and what we are talking are the chronic HBV infection, obviously. So the E positives who are previously called immune tolerant versus the previously called E negative, inactive. Would you like to differentiate? We know that the DNA obviously has a risk or increases your risk. The higher the DNA, more the risk of HCC or cirrhosis. So would you like to focus only on immune tolerant with high DNAs, or even within the inactive group, those who have very low DNA and still would like to treat all? You did emphasize on the cost effectiveness and all, but then how about the drug resistance if you start treating even the low DNAs? That is the first question. And the second is, in this kind of scenario, treating all with DNA positivity, can the surface antigen quantification and the correlated antigen, can that help you in substratifying these patients at whom to treat and whom not to treat? Thank you.
Fantastic questions. And you're, I would say, moving into that world of complexity with these different questions. And if you look across our 7 different factors and why we treat individuals, you will be able to come up with 1, 2, or 3, or maybe 6 reasons to treat every person who's DNA positive. You're right, there are correlations between DNA levels and liver cancer, DNA levels and cirrhosis risk. But those individuals with very high DNA, low levels of activity, may not have much fibrosis, formerly known as immune tolerant. Those individuals are very infectious. You have another reason to treat them. High DNA levels, more inflammation. I believe the DNA levels correlate with quality of life. People feel better when they're fully suppressed. I've learned this from a variety of different patients. Correlated antigen might help you substratify patients at risk, but let's make it simple. If we make it simple, we're going to get to elimination. Let's join our HIV, hepatitis C colleagues. DNA positive, treat. HIV, treat everybody who's RNA positive. Hepatitis C, treat everybody who's RNA positive. We really need to move to this simplicity. Think about the 7 different reasons to treat. Think about the patient. Think about the community. These are reasons to embrace this very simple approach. I hope I answered your questions in a simple package.
Bob, one other question, just returning to that. When you take an approach, treat all with a DNA positive, you have to, would you be concerned about like compliance? Like, let's say someone is taking and certainly stop, and there's some risk of reactivations in this group of patients, especially in countries where, this is not the education, there is a lack of education, it might be much easier in the United States where, you can make sure they're monitoring, they're having frequent visits, but would you be concerned about reactivations and acute liver failure in those groups of patients?
It's a great question, and this really goes back to Ajay's question just a moment ago, which is resistance. Well, in tenofovir world, they've been able to identify 5 people in the world with tenofovir resistance. It doesn't exist. Those 5 people had 5 mutations to get resistance, and their DNA level was barely detectable. Of course, you have to have detectable to figure out the resistant mutations. So resistance is not on the table. Reactivation is. But if you spend your time motivating the patient to stay on therapy by good education at the beginning and a consistent message, part of the reason people are not compliant is they think it's hopeless. I'm going to be on this forever. There's drama. There's a sort of a mortality or fatality picture these individuals have. Give your patients hope. Don't use lifelong. Barely use the word indefinite. Just say you're going to be on this until we get better therapies or until S loss. But I think the reactivation and risk of fulminant liver failure, risk of death or transplant is markedly over exaggerated. It does happen, but we need to think about medicine, not be a surgeon. We need to be thinking about what is the global message, not the last case we saw. If you see one case of reactivation, is that going to change your behavior for your next 100 patients or next 1,000 patients? It might, but it's going to change your messaging. It's not going to change who you're going to start treatment. So reactivation risk with a fatal outcome, in my opinion, is a risk that's probably less than 1 in 1,000 patients.
Thank you. I have a lot of questions from Dr. Jayanti Venkataraman, and I'll go to that, and then we'll come back to our audience again. Dr. Venkataraman, please go ahead.
Most of the questions you answered, especially the anti-HBC related, and the other one was the recent one that you mentioned about the reactivation. I would like to know about the acute hepatitis B patients. Should they be treated? And the children who are HBsAg positive, should they be treated? With the high DNA.
Fantastic. So the first one with acute hepatitis B, really I think the most important paper actually came out of India, saying it's important to urgently treat those patients if they have abnormal synthetic function. I think there was a bilirubin maybe in the 5 range. But I get a DNA level. If the DNA level is very low, they probably don't need to be treated because they're probably clearing. They have a high DNA level and any signs of synthetic dysfunction. And I think direct bilirubin is the best synthetic test around. I would put them on treatment if their direct bilirubin is elevated. So that's my professional opinion. We know from the lamivudine study from India that if you treat with the bilirubins over 5, that I believe it makes a difference in the outcome. Your second question, can you say that again, please?
In children.
Who are children who are positive.
That's a hot topic. I'm not a pediatric hepatologist, but I think everybody who's DNA positive should be on treatment. We're getting pushback from our pediatric colleagues. Kathy Schwartz, who lives in San Diego, where I live, is a world famous peds hepatologist, hepatitis B-ologist. We can't treat all children, and she'd give me a whole list of questions, and then I would say, oh, here's a list of reasons to treat all children. So I think in my big picture, DNA positive treat, and there's lots of reasons. Children are stigmatized as much, if not more, than adults, and it's a major issue to those individuals. Children transmit hepatitis B horizontally, and that was been shown in New Zealand in the Maori native, the Aboriginal people. So I think we make it simple: DNA positive treat, and work towards a functional cure with our colleagues in the pharma world.
Thank you, Bob. Incidentally, that paper that came out from India in hepatology, lamivudine paper with Dr. Serene, I was actually one of the main author in that one too. Dr. Mubin Khan, you can go ahead.
Yeah, thank you, Dr. Satapathy, and that was a great, excellent talk. I had 2 questions. The first one, I was a part of that discussion with Dr. Analog, and there was a conversation where we'll treat or monitor. I was a little surprised to see, I don't know how much of a moment we had after that in combining, because I still see there was some talk about coming up with the guidelines to treat all in U.S. population. So I was wondering if your thoughts, if there is any momentum to combine and to send the same message across the guidelines. And number 2, pertaining to the post non-liver transplant situations where we get consulted on usually for Hep B core positive status. So in those scenarios, Hep B surface antigen negative, Hep B core positive, and non-liver solid organ transplants. Your thoughts about treating or separation antivirals versus monitoring. Thank you. Thanks again.
Okay, so number one, the ASLD is rewriting their guidelines. We will see how sensitive they are to these 7 factors. Are they going to just think about cancer and cirrhosis? I can't answer that question. I will say that it took a series of phone calls from me and a few other people to AASLD leadership to even talk about rewriting the guidelines. There was a perception that nothing's happened in the last 10 years in hepatitis B. Why would we rewrite the guidelines? Well, after a few phone calls, they became very aware that many things had changed, and it was time to rewrite the guidelines. And I'm hoping that they take what I call the China approach to treat everybody, because that's where the data is. I mean, we have the data to treat everybody. It's just how academic they want to be and what the threshold is. WHO has pushed back on rewriting the guidelines and treating all. They're getting pushback from governments who don't want to pay to treat because it's expensive, but it's cost effective to treat everybody if you look at all of these 7 different factors. Your second question had to do with transplant, core antibody positivity. There's 2 different sides to that, of course. If the donor is core positive, they're going to transmit hepatitis B 70, 80, 90% probability in the liver transplant world. So if the donor is core positive in liver transplant, you're going to be putting that person on a first-line nuke, entecavir, TDF, or TAF long-term, indefinitely, lifelong. If the recipient's core positive, they're obviously at risk of reactivation, but if you take out the liver, the risk of reactivation is quite low. And that is a setting where maybe vaccine with surface antibody might result in better immune control. In those individuals, I would think about monitoring, provided that their HBV DNA is negative. It's a longer discussion about heart, lung, kidney, pancreas, stem cell. We can get into maybe if we do a talk on reactivation. So those are my simple messages on transplant. I think HBIG should be off the table in 99% of patients, especially long-term. We have great first-line therapy. Most people do well with monotherapy with one of our first-line agents. Thank you.
Thank you. Dr. Yusuf Al-Khazo, please introduce yourself as well for the audience and then ask a question. Thank you.
Thank you, Robert, for best compact presentation. I have do you listen,
Yes, we're listening to you.
Yes, and I have 2 questions. First, if you have a patient with co-infection B and D and residual viremia with very low DNA level by B, do you suggest start combined treatment with DAA and NUCs at the same time, or check on treatment, for example, at week 4, and at NUCs depend of DNA level?
Great questions, Steve. Thanks. Great to see you. I put all of my Delta patients on NUCs if they have any level of DNA at all, and I believe that the DNA activity helps drive the liver disease in Delta. So simple message, DNA positive, Delta co-infection, they need to be on a nuke. Then, of course, I discussed with them about getting on bulevirtide. Bulevirtide's not approved in the US yet. Hopefully it will be soon. I just wrote a compassionate use application yesterday for one of my patients in Santa Rosa to be on bulevirtide. Yeah, I think it will be very simple. If you have Delta and you're Delta RNA positive, we're going to treat those people. We're going to follow this simple messaging you see. Thank you.
And the next one, what is the reason for very late seronegativation by E antigen on NUCs? I have a patient which on NUCs treatment 14 year, but he not destinate seroconversion by E yet. despite S antigen level significantly decrease?
It's a great question, and there are people who are e antigen positive who never clear E. If you look at the long-term data with entecavir and tenofovir, you're getting E seroconversion in only about 50% of patients with long-term viral suppression. This virus is clever, it's efficient. It makes a lot of E protein to be an immune decoy. There's a lot of reasons that Hep B makes E antigen, and we just can't get to E clearance. You see it in some of our patients until we apply our new technology. Remember, the iRNA and the ASOs target S, X, E, core. These are fantastic technologies, but they have their limits. That's why it's going to be combo therapy for B in the near term, unless we come up with dramatically new technology.
But in this case, what is the point for decision for stopping therapy?
You're not going to stop until they've lost S antigen plus 1 year. Super simple.
Thank you. Thank you very much.
Thank you. That's very clear. Dr. Dokumisi, your video is on. You're from Turkey. Dr. Dokumisi was former president of the APASL as well. Dr. Dokumisi, please go ahead.
Hi, Robert. Thank you very much for your really wonderful talk. And I have two questions. First one, as we know, DAAs has been encouraging us very much about the cure of the hepatitis C. But still, we have a lot of problems to cure the hepatitis B. Maybe this is really related with the cccDNA existence. I think it seems very difficult if we cannot eliminate the cccDNA. Of course, there are many new drugs, and there are some research about that. What do you think about the cure of the hepatitis B? The second question, we have a lot of cases of the ACLF due to hepatitis B reactivation. And of course, nucleoside analogs, entecavir, TAF or TDF. Which one use according to your experience? Thank you.
Okay, so first question, Adir, is very important. This issue about cure, the cccDNA, the integrants. Yes, we have challenges, but we know that if you have immune reactivation in a controlled setting, you can suppress S antigen to undetectable, DNA undetectable, because we see this happen naturally. If you're an adult and you get hepatitis B because of some risk behavior, 95% of patients clear S, clear DNA on their own with no help. It's all about the immune system in the end. We suppress virus with different tools, then we bring the immune system back in, and that immune control keeps them in the functional cure stage. But to get rid of cccDNA is going to require new technology, such as CRISPR-Cas9, this new ARCUS technology, and also the new epigenetic modifiers. And there's companies that are in that space as well. Modifying the epigenome can change what's happening with the interaction with cccDNA. cccDNA has its own turnover. Endonucleases are degrading cccDNA all the time, but the virus is just making new cccDNA. We shift that balance, we may be able to clear cccDNA. And the integrants, that's going to be a harder story. The integrants make surface antigen, so it can be a decoy. It can make you think you didn't get the functional cure, even if you've gotten rid of all the DNA, all the cccDNA. So eventually, in some patients, we may want to use our molecular tools and excise what's happening in the genome, or let natural events excise what's in the genome. The tenofovir story, the 2 papers on tenofovir that have been published, one from Hong Kong, and I think one from China, have shown that if you suppress virus, you have less integration and you have decreased transcriptional activity from the integrants. So nukes are doing part of it. We may have to complete that story with one of our newer technologies. So there is hope in that world, Kadir, for that. Your second question, sorry?
For the reactivation of the hepatitis B for the ACLF cases.
Oh, yeah, I think when people have reactivation, ACLF, they could go on entecavir, TDF, or TAF. The only place I'd make a caveat is if that patient was on lamivudine in the past and then was on entecavir, that ACLF might be due to resistance, the emergence of a resistant mutant. So TDF and TAF give us a lot more security that you're covering all the variants, you're covering all resistant potential mutants that are out there. But we've got great first-line therapy. It's just about early treatment and early reintroduction of treatment.
Just for my clarification, I want to ask you one other question about patients coming with acute liver failure going for liver transplantation. Is there any role of giving them antiviral therapy?
I think they should be on a nuke. Since they're going to be on a nuke afterwards, they should be on a nuke at the beginning. As soon as they come in, they're heading towards transplant. They need to be fully suppressed. And what's nice about full suppression is you need less HBIG, right? HBIG was being used because we had all these patients with extremely high viral loads, and we had weak nukes like lamivudine or adefovir. Or back in the day, I used ganciclovir. One of my papers I published in Hepatology 1992 or 1993. Ganciclovir has activities, but we got potent suppression, low virus. We may not need HBIG at all. That comes from CM Lowe's original paper with entecavir in Hong Kong.
Thank you. We're almost towards the end of the meeting, but I would ask allow two more questions. One, I can't read your name. The ID looks like Jamal1112. Please introduce yourself and ask that question, and then Dr. Jalal after that.
This is Ben.
Okay, Ben, please go ahead.
That was a great talk, Bob. Just a couple of questions. One, between entecavir, tenofovir, and TAF, I guess TAF is the best, but between tenofovir and entecavir, is there benefits in particular patients that, there are some papers that have claimed, that there is some benefit of TAF over entecavir. Is there any scenario like if they have very low viral load, would you use entecavir or tenofovir in that situation? And that's one question. And the second question is, I have a patient recently, again, the treat all strategy will work, I guess, in this patient, but he's a Turkish patient who has chronic elevations of liver enzymes. The viral load is like less than 1,000. And I looked high and low for other causes and couldn't. And then I put him on a suppressive therapy and his enzymes normalized. So is there a disparity between, hepatitis B DNA in the serum versus inflammation in the liver? And do we see that disparities, and is that significant clinically?
Bob, please unmute. You got muted.
Did the mutation, or did that on its own, right? My mutated. TDF and entecavir have been competing about which drug has a lower liver cancer risk. And Sanjaya, can you mute whoever is talking? There's some noise. I don't think we have an answer there yet. I think the really good studies say that entecavir and tenofovir are equal for liver cancer risk. But there have been some papers, especially from Korea, that suggest that tenofovir is better and has lower liver cancer risk. I'd say that's still for ongoing discussion. Your second question has to do with the disparity of ALT and DNA levels. You're right, some patients have a lot of inflammation. Other patients have much less at a given DNA level. And I think this is back to personalized medicine. Everybody's different. And everybody's got different immune response and different immune viral interaction. They have to do with the mutants that they have. They may have core, pre-core mutations. Those increase the risk of cirrhosis, inflammation, liver cancer specifically. But make it simple, DNA positive, treat, see what happens to the ALT. The ALT is persistently elevated in a fully suppressed patient. Reassess for metabolic syndrome. Talking about a Turkish patient, make sure you've got Delta testing on file in those individuals. And then just keep working that patient up. If you think there's alcohol, as you know, alcohol is the main cause of liver disease, one of the main causes of liver disease globally. Patients may not be truthful about how much alcohol they're making in their basement of their house, how much they're drinking. So get a PEth test, PETH, if you're assessing your hepatitis B patients. That's very important. Sanjaya, back to you.
Yeah, thank you so much. I would presume Jalal, patiently waiting for the last question. Doctor, I don't know that, Bob, you have any more, because we already had 4 minutes out of our time, but if you're okay, we can ask Dr. Casey from Nepal also asking one question. But
Sure.
Dr. Jalal, please go ahead.
Bob, it's always wonderful listening to you. It amazes me that hepatitis B, we kept on hearing for so long, but still raises so many questions. Now, Bob, I understand your point about any patient with Hep B DNA positive should be treated. The difficulty is the side effects are poverty, maybe because of cost. Then it comes with compliance. So if you got a young patient, 20, I have plenty of them, Hep B DNA positive, liver enzymes are normal. It's hard to tell them they will be on this treatment long term. I mean, I understand your point that until the cure is available. So can you and it's expensive. Most of the people, it's not like hypertension medication. It's cheap over the counter. And because the policies or whatever, it's not easily available, without insurance, and it costs a lot of money. Some of my patients have to pay $400 or $800 per month for this medication. So we need definitely, if you advocate this way, we need to change our policies and then access to medicine. Compliance is the issue, but poverty is really the problem. And then my next question is, in the basic level, the term used immune control. So what's the difference between immune control and occult?
Okay, that's 3 questions. Let me move quickly. I do have more time. My breakfast is in 35 minutes, so we're okay. Let's talk about costs for a second, since there's no side effects of these medications at any major level other than TDF. You have to monitor bone and renal health. So I have a patient in Vietnam that I see every year when I go and work there, and I bring entecavir from the US to Vietnam because he doesn't trust the local generics. I go to my pharmacy in San Diego, my federal clinic, I buy a year's worth of entecavir for $95. So in the US, you can find cheap medications. Or I've got patients, I have a lot of patients from India who live in the US, and they go back every year and they buy their entecavir or their TDF or TAF in India for a few $100s. You can get it shipped in from India through Canadian pharmacies. There's other ways to get these inexpensive drugs. You just got to take a little bit of extra time, but they can be cheap. Globally, tenofovir is about $50 a year. There's a lot of countries where they're already at that price point from a generic perspective, as well as work that Gilead did to dial in the cost of tenofovir based on local costs, such as GDP calculations. And the compliance message is spend more of your time educating your patient, less time looking at all these different complexities. DNA positive, you're going to treat, and you educate the patient the importance of compliance. This reactivation risk is very small, but it's real. It's another motivator. We think about compliance in hypertension and diabetes. We treat people chronically for decades. We don't worry about that. Why should we worry about in hepatitis B? If you educate your patients properly and you have a callback system, you make sure they're coming back every 6 months, they're getting monitored. And I think that's where you need to spend your time, Prasoon. But you're making the move. I hear you're coming over to this side of the fence.
Thank you. Dr. Casey, for the last question, please.
The other question, immune control. What's the difference between immune control and occult? Sorry.
Occult may be a form of immune control, but immune control in general is core positive plus surface antibody positive. Occult is core antibody positive alone. There's definitely some level of immune control. That's why they cleared S antigen if they didn't have a mutant. But OBI and immune control are two different diseases. In immune control, your chance of finding DNA positivity is under 1%. In occult hepatitis B, your chance of finding DNA is over 15%.
So do you believe then surface antibody positivity or titer has a role in preventing reactivation?
We have very good data that the higher the surface antibody titer, the lower the risk of reactivation, especially in settings such as rituximab. So surface antibody does relate to immune control, but that can't be induced by vaccine. Vaccine does not manipulate that. That's what the natural host viral response, immune response, what that reset is.
So you mean giving extra shot of vaccine, which you despise or you didn't like, increasing the HBS titer by an amnestic response has no role. On the other hand, if you have anti-HBS spontaneously, even if it becomes negative over time, you're okay with it.
We have no data, Prasoon, that vaccinating decreases the risk of reactivation. And there's one study from Japan, which I'm still trying to find the paper, but there's an abstract that said vaccine did not decrease reactivation, had no effect on reactivation risk. So with natural S response, that is good immune control, lower reactivation. But if S titers fall over time, in the setting of rituximab as an example, the risk of reactivation goes up. That has been published. I think it's from the Texas group, but I'll have to look up the source. Complicated questions.
What do you recommend for that? If the surface antibody titer falls over time spontaneously, and then you're getting rituximab, you still don't want to give vaccine shot to boost it up.
No vaccine. I'd put them on a nuke if that surface antibody titer fell less than 10. Super simple.
Wait, you said if this surface antibody titer is less than 10, you will give a shot?
No shots, no vaccines, no boosting.
No.
Would use a nuke if the surface antibody titer fell less than 10.
Okay. I see. Got it. Okay. Thank you.
Those are excellent discussions, great questions, Prasoon. I think this for the audience is very important, those to clarify these questions. Dr. Casey, you got the last question. Please go ahead.
Thank you, Sanjay, for giving me a chance. Dr. Gish, it was a nice presentation as usual. My question is that you told that even in case of pediatric age group, all SBB DNA positive should be treated. Is it true for all those who are ALT, normal ALT, or for those who have raised ALT?
ALT is not in the algorithm. DNA positive, treat. Of course, if the ALT is elevated, you're going to look for alcohol, fatty liver, delta. You've got a lot of other places that you will go. But let's keep it simple. 5-line guideline, DNA positive, treat.
Okay, so you're telling that TAF or TDF is costing $50 per year, but in Nepal is around $200. And I'm sometimes treating patient in the area where prevalence is around 25%. So it's very difficult to have all those treated. So what can be done in those areas where the prevalence rate is more than 15%?
Fantastic question. And of course, this does what we have called a blowback when you have this advocacy position. But if we do move and we have recommendations to treat everybody, then we go back and renegotiate a lower price. And that's where we need to have advocacy, providers, governments working together and going back to pharma and saying, look, we're going to take the number of people on treatment up 5-fold. Let's have a price reduction so we can make this cost effective and cost accessible. Because sometimes cost effectiveness is a calculation. but it's not the real world where an individual patient has to go into a pharmacy and pay out of pocket for at least part of their treatment. So we want to do the right thing, which is treat everybody, and then let's go back and negotiate price reductions based on what's happening in a given country, in a given region economically.
And with
last
that,
question, if I'm allowed. Last question, so please. So you're telling that we should be treating the pediatric age group also. But in my country, where only one strength is available and we don't have in syrup form. So in that case, how we adjust the dose to the pediatric population?
Fantastic question. And yes, that is a challenge. But if we move to treating everybody, treating peds, we can go back to people making entecavir. Entecavir is definitely in a liquid form. There's lower dosing forms of tenofovir that are becoming available also. We just need to make sure we move that globally. So let's move together, treat everybody, and then get access to the right dosing. Great question.
I think
Thanks
with
very
that, those are fantastic questions, and I think we ended up with the best one as well. Thank you, Dr. Casey, as well for joining and asking that question. And Bob, thank you for your time. I mean, I really went, this is 15 minutes beyond our anticipated time. So thank you for staying and sticking into all these questions and answering that thoughtfully. This is great discussions. And again, thank you everyone for joining. And again, we would like to see you all in 2 weeks with another great talk. And Bob, thank you so much. And it's an honor to have you in our forum today.
Bye, everybody.
Thank you, everyone. Thank you, Robert.
Thank you.